A very good morning. I am Dr. Rahul from Surgical Gastroenterology Department at CPJ. I will be talking on acute pancreatitis management. Next, we will be starting with a brief introduction of pancreatitis and then followed by question-based answer system so that everything becomes clear. So, just to start with, the acute pancreatitis can occur at any age, whether it be young and more commonly young men and older women. And 3%, it forms the 3% of all causes of abdominal pain, mostly acute abdominal pain. Only 10 to 20% of the acute pancreatitis are severe, and biliary and alcoholic causes account for around more than 80%. So the initial symptom is usually severe abdominal pain in the upper abdomen, with or without fever, and maybe associated with vomiting. So next, please. So what are the differential diagnoses? So if a patient with acute abdominal pain in the upper abdomen comes, what should we think of apart from pancreatitis? Because pancreatitis is not that common. Next. So there are multiple causes related to all the organs situated in the upper abdomen. So if it is related to, say, stomach and esophagus, it can be esophagitis or gastritis. It can be acute pancreatitis. It can be gallbladder related like cholecystitis or cholangitis. It can be hepatic liver abscess. It can be basal pulmonary inflammation, pleuritis, and it can be as grave as myocardial infarction or pericarditis. So, physician should be very alert about all these conditions. But the most probable differential diagnosis related to acute abdomen in the upper part of the abdomen, involving the upper part of the abdomen, is acute pancreatitis, perforation pericarditis, that is peptic ulcer perforation, and acute cholecystitis. So what are the criteria? So there must be a diagnostic criteria for acute pancreatitis so that we can establish the diagnosis of acute pancreatitis in patients with acute abdomen, and we should know what imaging we should do to confirm if it is required. Next, please. So the diagnosis is based on Atlanta classification. So revised Atlanta criteria says that any two of these three features, if they are present, then it can be termed as acute pancreatitis. One of the features is acute abdominal pain in the upper abdomen mostly. The serum lipase or amylase activity is more than 3 times the upper normal limit. Usually the upper normal limit at various places is 90-95. So if it is more than 300, then it can be termed, it can be considered as acute pancreatitis. And the third is, if the abdominal pain or serum amylase lipase is not available, this characteristic finding of acute pancreatitis on imaging, because ultrasound is widely available everywhere. So if you do an ultrasound and features of pancreatitis are seen in ultrasound, which I will be discussing later on. So in any of these two of these three criteria if they are present, then it can be termed as acute pancreatitis. Next, please. The question arises, what are the common etiologies of acute pancreatitis? So here are the etiologies. The most common being, next please. The most common being gallstones and alcohol, as I already said. They account for 70 to 80% of the causes of acute pancreatitis. Even in the West, gallstone is one of the most common causes of acute pancreatitis. Apart from that, there are many rare causes like hypertriglyceridemia, genetic causes, genetic predisposition may be there, drugs may be related to acute pancreatitis, and autoimmune causes of acute pancreatitis can also be there. And one of the more common causes in young children is trauma. If they fall forward or they are hit by the handle of the bike or cycle, then it may cause acute pancreatitis in these young children. ERCP-induced acute pancreatitis can also occur, and ERCP can 5 to 10% of all ERCPs can lead to acute pancreatitis. So mostly it is a mild pancreatitis, but severe pancreatitis can also occur following ERCP. Next. Now coming to the common causes, say first the alcoholic pancreatitis. So alcoholic pancreatitis, as I said, accounts for 30% of the all causes of pancreatitis, and it is usually a binge drinking episode on a background of chronic abuse of alcohol. That increases the risk. It is not that once or twice if you take alcohol you will develop pancreatitis. So if it is binge drinking on the background of chronic abuse can increases the risk. And there is no association with amount or type of alcohol or pattern of consumption. But yes, binge drinking does have more effect. And there are various pathophysiology which is related to alcoholic pancreatitis. That is, alcohol can be metabolized releasing oxidative stress, which usually affects the glands and the organs and can cause pancreatitis in these patients. Next. The second most common cause is biliary pancreatitis. There are various theories behind biliary pancreatitis. One of them is common channel theory. that there is a common channel of bile duct and pancreatitis, but this theory doesn't hold very good because the thing is that the pancreatic duct pressure is always higher than the biliary pressure. It is unlikely that the bile can traverse to the pancreatic duct, and it has been proven in animal studies. So it is not very well considered. The second theory is incompetent sphincter theory, but this also not goes very well because nowadays the RCP is very common and many patients undergo sphincterotomy. Even after sphincterotomy, it doesn't increase the chance of pancreatitis. So incompetent sphincter theory is also not very well taken. But the most accepted theory is co-localization theory. That is because of ductal hypertension that the glands rupture and there is co-localization of the lysosomal enzymes and the pancreatic enzymes which get activated inside the gland and can cause biliary pancreatitis. So co-localization theory is the most commonly accepted theory for as a causative agent for biliary pancreatitis. Next, please. Now coming to how to classify the severity of pancreatitis. What constitutes local and systemic complications, and do we have any scoring systems for them? So it is very important to classify the severity because based on that we'll decide the management of pancreatitis. Please next. So there are various scoring systems which are available for acute pancreatitis which range from which are pertinent to ICU patients. So there are multiple criteria. So many scoring systems have been developed just because none of them are very accurate. So one of the most common is organ failure based scoring system, that is Marshall and SOFA, and the other is BICEP scoring system, that is website assessment for acute pancreatitis, and these two are very commonly practiced and they have been proven to correlate with severity and mortality related to pancreatitis. There are few biomarkers also available. So if it is the CRP, C-reactive protein is more than 150 mg per liter, or IL-6, which is done nowadays commonly in majority of the centers, it is more than 122 picogram per ml, or procalcitonin if it is more than 2 nanogram per ml at the time of diagnosis or at the time of presentation, then it is termed as, comes with the criteria of severe pancreatitis. Next. So severity of pancreatitis has been classified multiple times. So last classification by revised Atlanta classification in 2012, which considered three categories: mild, moderately severe, and severe. So mild was considered as pancreatitis which does not lead to any organ failure or any local complication, while moderately severe pancreatitis, which was considered as transient organ failure, that is organ failure which could resolve within 48 hours of presentation or with resuscitation, and severe pancreatitis is related to persistent organ failure, single organ or multiple organ. That was not separated, but yes, if there is persistent organ failure, then it is termed as severe pancreatitis. Now, in the same year, determinant-based classification came up, and this was based on which was based on deciding what to offer to the patient. So it was more elaborate, and it considered four categories: mild, moderately severe, severe, and critical. So mild and moderately mild pancreatitis is same. There is no pancreatic necrosis or organ failure. Moderately severe is considered as pancreatitis which leads to sterile peripancreatic necrosis or transient organ failure. It is similar to the revised Atlanta. The severe category included infected pancreatic necrosis or persistent organ failure more than 48 hours, while critical considered infected peripancreatic necrosis and persistent organ failure. So there was difference in severe and critical in the terms. In severe, it was non-infected. It is a mistype. It is non-infected peripancreatic necrosis or persistent organ failure, and it becomes infected, and it is termed as critical. Next, please. So there are various local and systemic complications of pancreatitis as stated. Local complications include acute peripancreatic fluid collection or cirrhosis formation or necrotic collection or walled-off necrosis, which I will classify in subsequent slides. But systemic complication is termed as exacerbation of pre-existing comorbidity such as CAD, that is chronic coronary artery disease or chronic lung disease precipitated by acute pancreatitis. So in a setting of background of acute pancreatitis, the patients become these comorbidities that are pre-existing with the patient, they exacerbate. That is the systemic complication of acute pancreatitis. Next, please. So how do we define organ failure? As I was always telling that the organ failure decides the severity of pancreatitis. So we should know how to define the organ failure. There is a Marshall scoring system which includes three criteria: respiratory, renal, and cardiovascular. So if any of these failures have a score of more than 2 or more, then it is considered organ failure. So in terms of respiratory, if the PaO2 by FiO2, if you do a ABG and you get a pressure of oxygen divided by the fraction of oxygen which has been administered to the patient is between 200 to 300, or if there is a serum creatinine which goes above 1.9, or there is a cardiovascular compromise in the terms that the systolic blood pressure is less than 90 and not responsive to the fluid, then it is termed as organ failure in terms of respiratory, renal and cardiovascular. So next. So now comes what are the priorities of the management in acute pancreatitis. You have already done the staging, you have already diagnosed the pancreatitis, you have determined the severity. Now you should know what are the priorities in the management, and you should know what fluid should be given and which fluid is preferred. So next. So all these priorities are considered for patients with severe acute pancreatitis. Mild pancreatitis do not need much of attention. They can be managed at any center. Even moderately severe pancreatitis do not have any organ failure, so they do not, once you do an initial resuscitation, the patients resolve on their symptoms on their own. It is about severe acute pancreatitis and partly moderately severe pancreatitis that you need to follow all these management protocols. And in all cases of acute abdomen, the first and foremost is ABC, that is airway, breathing and circulation. You have to take care of airway, which is very commonly affected in acute pancreatitis. So if the patient is low on oxygen saturation or something like that, you can supplement oxygen, and if required, may require intubation also. Even breathing pattern has to be checked for. Circulation is very important. That if the patient is low on BP, you should resuscitate with fluid, and if it doesn't take care of the blood pressure, then you may have to add vasopressors. So followed by IV. So IV fluid is one of the most important factors in the initial management and should be goal-directed intravenous fluid therapy. Followed by analgesia, which is always step ladder pattern. You go on analgesia, and the most important thing which comes 1 or 2 days later is nutritional support. So next, we'll take all of them one by one. Next, please. So coming to fluid therapy. So there is massive release of cytokines in acute pancreatitis, which causes severe inflammatory response syndrome and profound intravascular fluid loss. There is mixed hypovolemic and distributive shock because there is vasodilation, and there is some amount of third spacing of the fluid. So the patients, because of this hypovolemic and distributive shock, patient may develop multi-organ failure. So adequate fluid resuscitation and maintaining intravascular volume is very important. It is considered as the mainstay therapy of acute pancreatitis, and all available guidelines underline the importance of fluid therapy in acute pancreatitis. So what fluid and how much to be given comes next, please. So this is how we should consider fluid therapy in acute pancreatitis. As soon as the patient comes, we should give a bolus of 10 to 12 ml per kg, followed by 5 to 10 ml per kg per hour in the next 24 hours. And then once you achieve a few targets, which are the targets include the urine output of more than 0.5 ml per kg per hour, heart rate of less than 120. It is preferable that if the heart rate is below 100, and MAP, that is mean arterial pressure, should be more than 65. Hematocrit should be less than 40, and blood urea nitrogen should be less than 25. So these are the resuscitation targets. But we need to find out whether aggressive fluid therapy should be given or moderate fluid resuscitation should be done. So there was a trial which was based on 249 patients, which considered aggressive fluid therapy in one arm and moderate fluid resuscitation in one arm. So aggressive fluid therapy included 20 ml per kg bolus in the first hour, and then followed by 3 ml per kg per hour. While the moderate fluid resuscitation considered 10 ml per kg bolus in first 2 hours and followed by 1.5 ml per kg per hour, and they always took into account the various targets which I have already stated. So they evaluated the patient, both the groups, at 12 hours, 24 hours, 48 hours and 72 hours, and fluid was adjusted as needed later on. Next, please. So what they found was, in hospital, moderately severe or severe acute pancreatitis, that did not differ. Whether the patients developed severe or severe acute pancreatitis, it did not differ in both the arms. There was fluid overload found in the aggressive arm, and which required more of hospital stay. but there was no difference in any organ failure or any local complications in both the arms. So the conclusion was that aggressive fluid resuscitation should not be done, but it should be more goal directed. It should be moderate amount of fluid should be administered, and this helps in improving the symptoms related to fluid overload and does not affect the outcome of the pancreatitis. Next, please. Now, the question arises, which fluid? Usually, we start infusing normal saline. But the fluid of choice in acute pancreatitis is isotonic balanced crystallized solution, and normal saline is usually a hypertonic solution. So, normal saline should not be considered. It usually causes hyperchloremic metabolic acidosis in patients with acute pancreatitis. So, there was a meta-analysis presented by published by Zhu et al., and they considered 4 RCTs which compared normal saline versus ringer lactate in acute pancreatitis, and they found that ringer lactate was better in terms of lowering the risk of developing moderately severe or severe pancreatitis. It led to less ICU admissions and ICU stay. It led to less local complications, and it also had an anti-inflammatory effect. So, the fluid which is best for acute pancreatitis patients is ringer lactate. Next, please. Now, coming to specific management in acute pancreatitis. There is a notion that if biliary pancreatitis, we should go for ERCP, but I should caution that ERCP is not indicated in mild biliary pancreatitis without cholangitis, and even in severe pancreatitis, it should be considered only when there is less doubt about cholangitis. Only in presence of severe or moderately severe cholangitis that a patient should undergo ERCP. It should not, if there is only severe biliary pancreatitis and there is no evidence of cholangitis, then we should not consider ERCP because it may be counterproductive at times. So, ERCP should be done only in patients with cholangitis with shock or moderately severe pancreatitis. There are few other conditions in which acute therapy may help in, specific management may help in acute pancreatitis, like in patients with pancreatitis caused because of hypertriglyceridemia. If we start with insulin therapy or do a plasmapheresis, then triglyceride levels can be lowered down, and that may affect the course of pancreatitis. And in autoimmune pancreatitis, which is rare to diagnose and acute setting, steroids may help because that doesn't come into the picture on day 2. It is only a diagnosis of exclusion, and once we have diagnosed autoimmune pancreatitis or the patient is known case of autoimmune disease, then may consider steroids, but it should not be given very frequently. So, next. So, what is the indication for timing of the initial CT assessment in acute pancreatitis? So, we have done the staging, we have done the severity, we know the severity. Now, how to do the imaging? We were talking about that imaging should be done in acute pancreatitis, but when should CT be done? So, early routine CT scanning is not recommended in acute pancreatitis, and there is no evidence that early CT improves clinical outcome. In fact, CT scoring systems are not superior to clinical scoring systems. So, scoring in the acute phase or the early phase will not influence the treatment. And apart from that, it poses risk of contrast allergy and nephrotoxicity. In these patients, already all organs are in a compromised state. So, we should not, put more stress on the kidney in terms of contrast infusion. So, early CT is not indicated. So, when is CT indicated? Next, please. So, CT is indicated when there is a diagnostic uncertainty. So, we are not sure whether it is acute pancreatitis or perforation peritonitis or acute cholecystitis, or the patient or the ultrasound is not showing the picture we want to see, or it is not very clear about the diagnosis. Then we can consider CT scan in early period. Or if we are contemplating a complication related to pancreatitis. So, there can be perforation associated with pancreatitis, there can be bleeding associated with pancreatitis. In all these cases, we should do CT scan. And if these things are not present, then the optimal timing is termed as CT should be done as late as possible, not before 7 days or 10 days of pancreatitis. And or if CT has been done earlier, then the next CT is done if there is a new clinical deterioration or if an invasive intervention is considered. Next, please. So, based on the CT scan or clinical evaluation, what are the morphological types of pancreatitis we should know about it, and how do you classify the collections? I was talking of collections in earlier, so now we will classify the collections, and if CT is done, how do we score the pancreatitis based on the CT? Next, please. So these are the two morphological types, that is interstitial edematous pancreatitis, when there is inflammation and enlargement of the pancreas with fuzzy margins and maybe few peripancreatic collections, but there is no necrosis of the pancreas. There is no decrease in the enhancement of the pancreas at any place. But the other type is necrotizing pancreatitis, where there is necrosis involving both the pancreas and the pancreatic tissue. So this is because of end arteritis and blockage of the vessels, and that causes ischemia followed by necrosis of the pancreatic tissue as well as the peripancreatic tissue. This is termed as necrotizing pancreatitis. Next. So the morphological classification of pancreatitis can be further divided into interstitial and necrotizing, as I stated, and if it is less than 4 weeks and interstitial pancreatitis is associated with few collections around, it is termed as acute peripancreatic collection. If it is more than 4 weeks and the collections are well defined, then it is considered as pseudocyst. While in necrotizing pancreatitis, if it is less than 4 weeks and the collections are there, it is termed as acute necrotic collection. If it is more than 4 weeks and the necrosis is well walled off and the boundaries are well seen, then it is termed as walled off necrosis. Next, please. So this is how we score the pancreas based on the CT scan. So if the pancreas is normal, it is given a score of 0. If there is interstitial pancreatitis, signs of interstitial pancreatitis, then it is given a score of 2. If there is peripancreatic collection or fat necrosis, then it is given a score of 4. Now in terms of pancreatic necrosis, if there is no pancreatic necrosis, it is given a score of 0. If it is less than 30% of the organ is involved and it is ischemic, then it is given 2. If more than 30% of the organ is involved, it is given 4. And apart from that, if there is extra pancreatic complications in terms of pleural effusion or vascular complications like splenic artery blockage or the thrombosis or the splenic vein thrombosis, or there is any gastrointestinal tract involvement, then it is given another 2 points. So maximum score is 10 and minimum score is 0. Next, please. Now, how to initiate nutrition in all these patients, because we have classified, we know how to manage initially, but we told in that initial management that nutrition is one of the important factors. So now we should know how to initiate nutrition, when to initiate nutrition, what food should be prepared, and what is the target protein and calorie one would want to achieve. Next, please. So in mild cases of acute pancreatitis, oral nutrition is well accepted, maybe from day 1, day 2 or later. But mild acute pancreatitis does not need much of concern. If it is moderately severe pancreatitis, they also may tolerate oral nutrition by day 2 or 3. But it is more in cases of severe acute necrotizing pancreatitis where oral nutrition may not be handled by the patient because of severe perigastric inflammation. So in all these cases, enteral nutrition can be given either by a nasojejunal tube, which is preferable over nasogastric, because if the nasogastric route is tolerated, then oral nutrition may also be tolerated. But in patients who are intubated or who are on ventilator, in those cases, these two routes can be compared. So if the patient is tolerating nasogastric through the nasogastric route, well and good. If he or she is not tolerating through the nasogastric route, then nasojejunal tube is placed and the feeding starts. So what are the benefits of enteral nutrition? What it does is it maintains the gut mucosal barrier, because it maintains it prevents the translocation of bacteria from the translocation of bacteria from the large bowel and small bowel to the blood vessels. And this is because when you give enteral feeding, the bacterial milieu of the intestine, that is maintained, and it may also prevent infected necrosis, because translocation of bacteria is not only to the bloodstream, but it also translocates to the collections as well. So through the enteral route, what we want to achieve is a calorie requirement of 25 to 30 kilocalories per kg per day, and a protein requirement of 1.5 grams per kg per day. So this is what we want to achieve in patients whom we want to initiate nutrition. So even in various guidelines, say American guidelines, they suggest that early within 24 hours oral feeding should be initiated as tolerated, and this is usually possible in acute mild or acute moderate pancreatitis. If the patient is inability to feed orally, then either enteral or parenteral nutrition should be considered. And in severe pancreatitis requiring tube feeding, either nasogastric or nasoenteral tube should be given, and these all follow a strong recommendation. Next. So, how do we give nutrition in patients of pancreatitis with raised intra-abdominal pressure? Because pancreatitis patients do have a raised intra-abdominal pressure. So, if it is severe acute pancreatitis and intra-abdominal pressure which is measured through the urinary bladder is less than 15 milligrams of mercury, then enteral nutrition by a nasovaginal tube or nasogastric tube can be given. If it is severe acute necrotizing pancreatitis with IFP of more than 15, then nasovaginal tube feeding can be initiated at 20 ml per hour. We should consider various methods to decrease the intra-abdominal pressure like drainage of collections or adequate antibiotics or and goal-directed therapy, and to may use diuretics to decrease the intra-abdominal pressure because there is clogging of fluid in the interstitium of the intestine in the peritoneal cavity. So if we can usually use diuretics, that may help at times to decrease the intra-abdominal pressure. But if the patient has severe acute pancreatitis and has abdominal compartment syndrome, that is IFP is more than 20, then enteral nutrition is stopped temporarily and the patient is started on total parenteral nutrition. In these cases, we consider all the methods to decrease the abdominal compartment syndrome. One few of them I already stated, that drainage of collections, use of diuretics, and at times laparoscopy is also made, that the abdomen is opened and left open with a Bogota bag in situ, so that the abdominal pressure decreases. Next, please. So another question in pancreatitis, marginal pancreatitis, role of antibiotics in acute pancreatitis. What is the timing and what should be the choice? Next. So it should be very clear that initial part of pancreatitis is because of the symptoms are because of severe inflammatory response syndrome, and that is not synonymous with infection. Though it is indistinguishable from sepsis, but it is not synonymous with infection. So at the initial part of pancreatitis, that say 1 week or 10 days, it is antibiotic prophylaxis is not recommended even in severe acute pancreatitis. But infection at other sites, if it is suspected, say a pulmonary infection is suspected or a perforation is suspected or cholangitis is suspected, then it may administer antibiotics and send for the pertinent investigations. If the patient develops infection, say in the second week or third week of pancreatitis, then in those cases, if there is infected necrosis or extra pancreatic infection, then we can always use antibiotics judiciously. So what choice we are coming to that. Next, please. So antibiotics with good pancreatic penetrations are piperacillin tazobactam, the quinolones, carbapenems, and metronidazole. So these are the initial choices. And apart from that, we should consider the local antibiotic resistance pattern as well. So as I already said, 1 to 10 days, usually sterile necrosis, no antibiotics is required. More than 14 days, infected necrosis is common, infection in the necrosis is common. In that case, antibiotics should be initiated based on local epidemiology and the various properties of the local properties. So antibiotics with good pancreatic penetration, as I already stated, has been piperacillin tazobactam, quinolones, carbapenems, or metronidazole. Coming to empirical antifungals, but it should not be given empirically. But if the patient has repeated blood cultures negative and there is evidence of fungal colonization, then echinocandins are preferred to start with. Next, please. So the next question comes: how do we plan our intervention in pancreatitis? Next. So see, there are two pictures. On the right side, there is acute peripancreatic fluid collection, and on the left side, we can see that the fluid collection is well demarcated. There is a wall around the fluid collection. So we should usually wait for this wall formation to occur before we intervene, unless the patient is showing severe signs of sepsis or the patient is in septic shock. Next, please. So the indication of intervention includes clinical suspicion of infection, or there is clinical deterioration. There is ongoing organ failure for several weeks after the onset of acute pancreatitis, or there is evidence of abdominal compartment syndrome. If the patient is not improving on symptoms, or the patient has evidence of infection, that there is air in the collection, or the patient is in septic shock, then we should consider for intervention. Next. So initially we should always start with a percutaneous drainage. So it is usually done based on ultrasound or CT guidance, and the drain is used to relieve pus when it is under pressure in the necrotic collection. That will prevent bacterial translocation and will serve as a bridge to necrosectomy as well, because it provides a route to access that collection. Next. So what is the step-up approach? You must be knowing about step-up approach in acute pancreatitis, so I will be telling you in detail, please. Next. There was an article which was published in NEJM in 2010 which talked about the step-up approach. That was Panther trial, and it compared two groups. One of the group which included 43 patients, that in which step-up approach was applied. Step-up approach includes first the percutaneous drainage followed by minimally invasive surgery, and if that doesn't work, then we go for open necrosectomy. While step-down approach was implemented in 45 patients, in which primarily we went for open necrosectomy. So in that trial, the step-up approach was found to be superior on primary endpoint. That was, the primary endpoint was the survival of the patients. So there was 40% patients in step-up approach, while 69% of the patients in open necrosectomy approach who died. So in the step-up approach, overall fewer patients with primary endpoint, less exocrine insufficiency was seen because less of pancreas was removed, and there was no difference in recurrent or chronic pancreatitis based whether it was endoscopic or surgical intervention, or there was no difference in quality of life. So based on this trial, step-up approach became the norm. So because it is superior to the open necrosectomy approach. Next. So this is how we step up. If we find an infected necrotizing pancreatitis which is less than 4 weeks of onset, we usually try to manage with antibiotics. But if resolution occurs, it's fine. If it doesn't occur, then PCDs or endoscopic drainage is considered. If resolution occurs, then it's fine. If it doesn't occur, then video-assisted retroperitoneal debridement or endoscopic debridement is considered. If it leads to resolution, then it's fine. Otherwise, in presence of ongoing sepsis, we go for exploratory leptotomy, next, or open necrosectomy. Now, if the intervention radiology team has placed a CT guided transgastric drainage or left paracolic drains, the fever intensity reduces and there is improvement in the hemodynamic circulation. What is the ideal time of re-intervention? We should know what if a patient of acute pancreatitis bleeds and what are the indications of surgery. So, we should know when to step up. Next, please. So, there was a trial, that is Pointer trial, which was published in 2021, which compared two groups, that is immediate drainage group or postponed intervention in patients with infected necrotizing pancreas, and they found that whether we do an immediate drainage in a suspected infected pancreatitis or we delay it as much as possible till the organ failure is difficult to manage, the patients there is no difference in the outcomes or complications. In fact, patients with immediate drainage had required more of necrosectomy, and patients with immediate drainage required more intervention, although there was no difference in the primary outcome or difference in the complication rates. Next. Next, please. So, if there is a bleeding in pancreatitis, which is usually delegated, and it usually results from a ruptured pseudoaneurysm. So, frequency of fatal bleeding in acute pancreatitis has been reported to be to the tune of 1.2 to 14.5%, especially in severe acute pancreatitis. In these patients, CT angiography is usually done if a patient is stable to localize the site of bleeding, and percutaneous transcatheter angiographic embolization is usually effective in containing bleed from ruptured pseudoaneurysms in acute pancreatitis. Next. So, coming to surgical indications, which are limited to which are now a handful of indications only because of various minimal invasive therapy and intervention radiology, expert intervention radiology. Surgical indications are very few. One of them is well-defined collections not amenable to percutaneous drainage. So, maybe collections at the root of mesentery or at the head of pancreas, which is not amenable to percutaneous drainage, that will be considered for direct surgical therapy. If the patient has bowel perforation because of pancreatitis or because of catheter-related iatrogenic perforation occurs, then such patient may require surgery. In patients with persistent single or multiple organ failure refractory to supportive treatment, in those cases who are not responding as in step-up approach, we can go for surgery. And patients with bleeding which is uncontrolled even with embolization, then we may consider for exploration and packing. Next. The question 13 is what surgeries are performed and what are the concepts regarding surgical intervention. Next. So surgical options include open necrosectomy, that we give a midline incision, go into the pancreatic bed and do a necrosectomy, that remove the necrosed pancreas. And the other, now because of advent of good laparoscopic instruments, we can go for minimally invasive necrosectomy, that is through laparoscopy, or video-assisted retroperitoneal debridement, which is the second step up in step-out approach. Next, please. So, what are the concepts regarding surgical intervention? As in other organs, we would do a radical therapy. Say if there is a gangrenous gallbladder, we talk of cholecystectomy. If there is a gangrenous small bowel, then we consider resecting the small bowel as much as to the length that is gangrenous. But in pancreatitis, it is usually a conservative approach which we follow during the surgery. It is not like we go for pancreatic dissection. So an attempt, there should always be an attempt to conserve the maximum amount of pancreas which is functional. And more important, it is technically impossible to do pancreatic dissection in pancreatic necrosis because the planes are not at all clear. So there is the goal of surgery in pancreatitis is we should do less of resection. That is why we delay the surgery by more than a month or so, because it better demarcates the necrotic tissue and it causes less bleeding and less removal of the viable tissue. So we should delay the surgery as much as possible. The concept behind surgical intervention is we should delay the surgery as much as possible, at least beyond 1 month, and it should be conservative while doing a pancreatic necrosectomy. We should not try to remove the viable pancreas from the pancreatic bed. Next. So this is a summary of management of acute pancreatitis, which I would like to summarize with. So day 1 of pancreatitis, when the patient comes to you, you have to take a good medical and family history. You should talk about if the patient takes alcohol or not, if the patient is a known case of gallstone disease or not, and if the patient has undergone if the patient takes any drugs regularly which can cause pancreatitis, if the patient has undergone any investigation in terms of amylase, lipase or transarterial ultrasound, we should always ask the patients on this initial assessment. And then once the patient is diagnosed with acute pancreatitis, we should go for fluid resuscitation followed by adequate pain management, and we should initiate the nutrition as much as possible. Following this, we should try to stabilize the patient. If the patient in ICU, the patient is in organ failure, and we should try to grade the pancreatitis, whether it is severe acute pancreatitis or moderately acute pancreatitis. But if the patient has clinical improvement over the next 3 to 4 days, then no further intervention or imaging is required. But if the patient has clinical deterioration, then CECT may be considered in such patients. And in patients with mild acute pancreatitis, if the patient has resolved over 3 to 4 days and the cause is because of gallstones, then the patient should undergo cholecystectomy before discharge in a patient with mild acute pancreatitis. Next, please. So coming to week 2, 3, 4 and 5, and beyond, if the patient doesn't have clinical improvement, I said we should do a CT scan to find out if there is any local complication of the pancreatitis. So if there is fluid collections which are amenable to drainage and which may be responsible for persistent organ failure, we may consider for endoscopic or percutaneous drainage. If the patient improves, it's fine. If it doesn't improve, then we may consider repeat imaging, and we may consider a step-up approach in terms of endoscopic step-up or surgical step-up. So endoscopic step-up includes endoscopic drainage followed by endoscopic necrosectomy, and surgical step-up includes a video-assisted retroperitoneal debridement. If it doesn't work, it may be repeated. If that doesn't work as well, then it may be open necrosectomy followed by, and all throughout this period, the patients need to be evaluated and observed and treated in ICUs or HCUs during the course of severe acute pancreatitis. Next, please. So in the end, I would say that managing pancreatitis is like a game of battleship. You never know whether you will sink or you will float, but you should always try to follow the guidelines in terms of fluid resuscitation, in terms of surgical management.